He has had an illustrious academic career, trained at Bangalore Medical College and PGIMR Chandigarh, and bagged lot of gold medals. And what is of interest to rheumatologists is that he has a publication on outcome of lupus nephritis. Today he would be talking on alerts and red flags of renal involvement in autoimmune rheumatic disease and other diseases. Over to you, Dr. Vinod.
Thank you, Chairperson. So today I am standing between lunch and all of you. So I would like to quickly brush up my presentation. So here in this presentation I will be focusing on the spectrum of kidney involvement in autoimmune rheumatic diseases and how do we approach them, not going into the management aspect. So autoimmune rheumatic diseases are a heterogeneous group of disorders. They share a common clinical presentation and a disturbed immunoregulation, which most of them will have some amount of autoantibodies. The renal involvement can range from asymptomatic urinary abnormalities to the other spectrum where there is a rapidly progressive glomerulonephritis, which is termed nephrological emergency. So kidney involvement is definitely of a prognostic value because it is going to increase the morbidity and mortality in rheumatic diseases. So a few questions that we should ask ourselves when we see a patient which has combined rheumatological illness plus a kidney involvement. Is kidney disease a complication of rheumatic disease and its management, or are they both a manifestation of a single systemic autoimmune disease? Is rheumatic disease a complication of kidney disease, long-standing kidney disease, or they are two different entities which have implications with respect to treatment to each other? So kidney involvement in autoimmune rheumatic disease, as per any other organ involvement, can be directly involved by rheumatic disease itself, or it can be involved secondary to the medications used in the management of rheumatic diseases. The comorbidities that are present can also have a kidney disease which may complicate the treatment and management, and the long-standing CKD can have a rheumatic manifestations which has to be differentiated from a primary rheumatological illnesses. So coming briefly on the pathogenesis of kidney involvement, the kidney, in order to approach, we divide into three compartments: the glomerular, tubulointerstitial and vascular compartment. So this is the cross-sectional of glomerulus showing the mesangial, the glomerular capillaries, the Bowman's capsule, and the glomerular capillaries are lined by endothelium inside and outside by a visceral epithelial layer. So any systemic disease which has an autoantibodies or immune complexes, since it's a vast capillary network, they come and they get deposited these in the subendothelial or subepithelial layer, and they trigger an inflammatory response. They activate the complement. There is an influx of neutrophils and mononuclear cells, which leads to mesangial hypercellularity, endocapillary hypercellularity, and crescent formation. Crescent formation is the counterpart of rapidly progressive glomerulonephritis. So based on these pathogenesis, we approach this information is very important in the histopathology in the kidney biopsies. So this is the podocytes and these are the glomerular capillaries. They can have a subendothelial deposition. Sometimes when the antigen itself, the GBM, the antibody can come and bind, then have a linear representation of the antibodies along the glomerular basement membrane. Sometimes the complexes can also be deposited in the subepithelial layer. So we have a different patterns of histopathology, the kidney involvement. So these patterns are related to multiple rheumatological illnesses. So this list is a comprehensive list. So I briefly a tubulointestinal nephritis, which is more commonly seen in Sjogren's syndrome, and the necrotizing crescentic glomerulonephritis, which is more commonly seen in ANCA vasculitis. The membranous nephropathy can be seen in Sjogren's, polymyositis, inflammatory myositis, and class 5 lupus nephritis. So SLE is a prototype autoimmune disease. The incidence is highly variable. So with respect to the kidney involvement, around 50% of subjects can have overt renal manifestations at the time of diagnosis, and around 20% of patients have a renal limited disease without any extra renal involvement. So, so the most common finding in clinically is the proteinuria, and the other things are microscopic hematuria seen in 80%, and rapidly progressive glomerulonephritis is seen in 10 to 20% of patients. So the kidney biopsy is a must in the diagnosis of lupus nephritis, and it is indicated whenever there is a elevation in the serum creatinine or a decrease in the GFR without any explainable alternative cause, and proteinuria more than 1 gram per day without active sediments, and proteinuria more than 0.5 gram per day with active sediments. So why this biopsy is important, even if we have a confusion that in the clinically that SLE or not, the biopsy itself can be diagnostic of lupus nephritis. There are certain lesions in the biopsy which can tell that this is specific to lupus nephritis. Are on light microscopy, we have a wire loop lesions and hyaline thrombi. On immunofluorescence, the full house pattern, that is deposition of all immunoglobulins, IgG, IgA, IgM, and complements like C3 and C1q, and electron microscopy, the presence of tubular reticular inclusions are also specific for lupus nephritis. This is the Renal Pathological Society classification. This is based mainly on the glomerular involvement, divided into 6 classes. The class 4, the diffuse lupus nephritis, is most common. It usually presents with nephritic syndrome, that is hypertension, renal insufficiency, microscopic hematuria. And the class 5 lupus nephritis usually presents with nephrotic syndrome. So the clinical presentation and the biopsy, there is a poor correlation. Sometimes we have a very minimal proteinuria and we do biopsy, we find a class 4 lupus nephritis. So that also indicates and underlines the importance of kidney biopsy in lupus patients. So the management includes immunosuppression, HCQ, and non-immunosuppressive anti-proteinuric medications like AC or ARB inhibitors. The Sjogren's, the renal disease is seen in 4 to 60% of patients. This is because of the heterogeneity in the studies and the classification criteria used in the diagnosis of renal involvement. The acute or chronic tubular interstitial nephritis with defects in tubular function is the predominant lesion seen in biopsy-proven renal involvement. The type 1 RTA is also commonly seen in Sjogren's syndrome. So systemic vasculitis, the large Takayasu arteritis is a prototype of large vessel vasculitis. It can involve the aorta and its major branches. The renal involvement mainly occurs because of the ostial renal artery involvement, which leads to renal artery stenosis. The medium vessel vasculitis PAN usually involves kidney in the form of hypertension. The aneurysms, when they rupture, they can cause a perirenal hematoma and infarcts. The ANCA vasculitis, they are small vessel vasculitis. They involve the glomerular capillaries and they classically present as rapidly progressive glomerulonephritis. And the biopsy is usually necrotizing crescentic glomerulonephritis with pauci-immune pattern with less of antibodies on immunofluorescence. HSP, the kidneys are involvement is in 20 to 100% of cases, can manifest as microscopic hematuria, proteinuria, or renal dysfunction. The histologically, we usually see IgA nephropathy. Systemic sclerosis, the clinical involvement, renal involvement is less common, but however, in autopsy studies, it is seen that around 60 to 80% of cases can have a kidney involvement. The most systemic scleroderma renal crisis is the most the devastating condition. It's a more severe, potentially life-threatening complication, which is accompanied by malignant hypertension, thrombotic microangiopathy, and rapid decline in renal function. So this awareness is very important because early identification and early institution of AC inhibitors and good blood pressure control can mitigate the damage. Autoimmune myopathies, there are 2 kinds of kidney involvement. The first, there is a rhabdomyolysis with release of myoglobin, which can cause acute tubular necrosis, and the histopathology, we can identify a pigment cast nephropathy. Second, they can also have a glomerular involvement. In polymyositis, there is a mesangial-proliferative glomerulitis is the leading glomerular lesion, whereas in dermatomyositis, it is membranous nephropathy. The rheumatoid arthritis and other inflammatory arthritis, the kidney involvement can be because of the most common cause of kidney involvement is the drugs used in the management. The least common is the glomerular involvement. The drugs like non-steroidal anti-inflammatory drugs, DMARDs like the previous DMARDs, the gold penicillamine, which had a lot of kidney issues. So this is the prevalence of kidney disease in various rheumatological illnesses. So what are the other domain is the therapeutics used in the rheumatology and what are their effects on the kidney. So the most common, the drugs which as a nephrologist we are more worried are the non-steroidal anti-inflammatory drugs. They are good molecules, they are very effective in the management of rheumatological, especially in spondyloarthritis, but so before using these medications, we have to understand like what is the renal function in the patient and what are the risk factors for the drug-induced kidney disease so that we can use safely in patients without any kidney adverse effects. The NSAID usually causes afferent arterial constriction and it causes reduction in GFR. NSAIDs are implicated in all spectrum of kidney involvement from AKI to CKD, nephrotic syndrome, acute interstitial nephritis, and papillary necrosis. The risk factors for NSAID-induced acute kidney injury are patients with diabetes, hypertension, elderly individuals with a poor renal function, liver cirrhosis, congestive cardiac failure, and underlying chronic kidney disease, dehydration, and concomitant use of diuretics and RAS blocker. So this is already I have told. So other drugs like methotrexate, they are 90% clearance through kidneys. So high dose methotrexate can rarely cause crystal nephropathy, but the dose which we use in rheumatological illnesses, it is less common. The importance is it is predominantly cleared through kidney, and in CKD the dose has to be reduced to avoid systemic toxicity. The cyclosporin and tacrolimus can cause ATN and renal fibrosis. So we have to keep an eye on the comorbidities in the management of rheumatological illnesses. The most common comorbidities we see in the routine practice is diabetes mellitus, hypertension, obesity, and other cardiovascular diseases, because they are most commonly associated with chronic kidney disease, and they have an increased mortality resulting from the development of CKD, and the chronic inflammation is an underlying factor which increases the risk. So there are certain long-standing kidney diseases can have a rheumatological manifestations, especially those patients who are on dialysis. They have a dialysis-related amyloidosis. So beta-2 microglobulin, there is a deposition of beta-2 microglobulin in joints, bones, and periarticular tissues. And chronic arthritis such as degenerative osteoarthropathy and spondyloarthropathy can be seen in dialysis-related amyloidosis. So we have to differentiate this from the rheumatological illnesses. So how do we approach kidney involvement in when we see a autoimmune rheumatic disease patient? So first of all, we should know when to suspect and how to categorize and how to approach for the different compartments, glomerular, interstitial, and vascular compartment, identify the etiology, and complete the diagnostic arc and treatment and follow-up. So we have only not much in the assessment of kidney function. It is the urine examination and the GFR estimation. So the urine examination is very crucial. Even in the normal GFR, the early dysfunction usually indicates a proteinuria. So it has a diagnostic, therapeutic, and prognostic significance, and it is an indicator of future cardiovascular disease and mortality. So we had like urinary albumin and urinary protein, what to measure. So urine albumin is preferred over urine protein estimation, as albumin is the most commonly filtered protein in majority of kidney diseases. Whereas urine albumin estimation is more sensitive when there is a lesser degree of proteinuria. So, but whatever, urine albumin is more costly, and so we usually use, when there is a massive proteinuria, we use urine protein creatinine ratio or a urine 24-hour urine protein estimation. So we can classify the proteinuria into two classifications like glomerular proteinuria and tubular proteinuria. See, glomerular proteinuria will have a predominant of albumin and followed by high molecular weight proteinuria. Usually when we quantify the proteinuria, the per day when the patient has a more than 2 grams of proteinuria, it usually indicates a glomerular etiology. Especially if they are associated with RBC casts, microscopic hematuria, it usually indicates that there is a glomerular involvement. So in the tubular proteinuria, there is a deficiency of reabsorption of proteins in the proximal tubule. So there is usually subnephrotic range proteinuria, and majority of them will have a total protein excretion of less than 1 gram per day, and usually they are not associated with RBCs and WBCs, but exceptions are usually there. Now, how do we assess the proteinuria? Is it time collection is important, or we should go for a spot urine sample? So the 24-hour urine collection for estimation of quantification of proteinuria is a gold standard, but that has its limitations because it requires the 24 hours patient. Sometimes they are not cooperative and they may not accurately collect the urine samples. So we usually do a spot urine protein and albumin creatinine ratio to screen what is the amount of proteinuria, and if there is increase in proteinuria, then we can do a 24-hour urine collection and quantification of proteinuria. Urine albumin estimation, as already told, is technically superior and can be standardized and reproducible easily across the world, and it usually in studies it is correlated with the heart clinical outcomes, but it is expensive. So when there is a high degree of proteinuria, in follow-up we usually use urinary protein creatinine ratio. So other information that a urine gives is the microscopic hematuria. Here the second image, it shows the dysmorphic RBCs, which usually specific for a glomerular hematuria, and the rightmost corner is the RBC cast, which usually indicates a glomerular involvement. Now next, the second step in the assessment of kidney function is the GFR estimation. Usually we do routinely with serum creatinine. So before understanding, we should understand what is exactly the serum creatinine is. It is basically a product of metabolism of phosphocreatinine in muscle and is usually available in meat and creatinine supplements. So it's because we use creatinine, though it is not a good marker because it is easily available, low cost, and it can be easily reproducible. So we have different equations are there to estimate the GFR based on serum creatinine. We routinely use CKD EPI equation to estimate the GFR. So creatinine, is it an ideal marker? So absolutely no. So because tubular secretion of creatinine increases when there is a reduction in GFR. There is increased intestinal elimination of creatinine also. So when there is a reduction in GFR, the body adapts to excrete the creatinine so that it overestimates the GFR. So extrarenal elimination of creatinine increases when its serum creatinine increases. So classical clearance techniques require accurate urine collection, which is routinely not possible to perform on a OPD day-to-day practice. So it's very insensitive to even substantial decrease in GFR. So this curve demonstrates the same thing. So here in the x-axis we have a glomerular filtration rate. As the GFR comes down, see, we can see that up to 20% the GFR, 20 ml per minute, the rise in serum creatinine is very, very minimal. So the rise in creatinine from 1 to 1.5 is very significant, and there is a rapid fall in GFR compared to a drop of creatinine or rise in creatinine from 2.5 to 3.5. So it's not a linear correlation. So the third step what we use is kidney biopsy. So kidney biopsy is usually required to establish the type of kidney disease, and it is a gold standard in identifying what's happening with the kidney. So kidney biopsy not only helps us to confirm the cause of kidney involvement, it also gives a lot of other information like what are the active lesions and what are the chronic lesions to decide on the immunosuppression. Sometimes there is a proteinuria. Proteinuria we cannot differentiate whether the biopsy has an active or a chronic lesions. So if the patient has a predominant active lesions, so there is the immunosuppression, there is the benefit of giving immunosuppression to the patient. So we can also identify any coexisting alternate pathology. Sometimes two lesions can exist together. For example, a diabetic patient with SLE, there can be a diabetic nephropathy with lupus nephritis. So we can assess the varied involvement of different compartments because different, like for example, a thrombotic microangiopathy has a different prognosis in an SLE patient. So we usually analyze the biopsy through light microscopy and immunofluorescence, and electron microscopy is utilized in rare patients where, so this is a few example microphotographs of light microscopy, which is showing the glomerulus. So here this shows a lot of mesangial hypercellularity, which is usually seen in IgA nephropathy, and the more concerned is this one, the Bowman's capsule is filled with the crescents. Usually it's a crescentic glomerulonephritis. So immunofluorescence looks like this. The subendothelial deposits, so whenever the immunoglobulins are deposited along the glomerular capillary wall in a fine granular fashion. So linear deposits usually appears like this, which is seen in anti-GBM disease. Subepithelial deposits are seen like this. So what should alert a rheumatologist regarding the kidney involvement? So when they are managing a primary rheumatological disease, the awareness of its predilection towards renal involvement is very important to screen early for the kidney involvement. And when the patient has a risk factors for kidney disease like diabetes, hypertension, and obesity, chronic NSAID use, patient has and over-the-counter medication abuse, definitely we have to screen, identify the underlying kidney involvement. Any patient has used native medication intake, it's also upcoming important risk factor for a chronic interstitial nephritis. Like clinical indicators like hypertension, patient having edema, frothuria, or lower urinary tract symptoms should also alert a clinician for a possible kidney involvement. So the conclusions, renal involvement is more common in autoimmune rheumatic diseases. Systematic estimation of GFR, even at normal creatinine, and assessment of urine dipstick is necessary in all rheumatological illnesses for early detection. Systematic evaluation of kidney involvement is necessary, and it requires a multidisciplinary team involvement and shared decision making by involving rheumatologists, nephrologists, and pathologists. And the use of nephrotoxic therapy should be avoided whenever possible, and other drugs to be used especially with low GFR. Thank you very much.